All right, here we are. Thursday at 8. It's time to party. So, you guys know the drill. I'm going to pull up the chat right here. If you can hear the sound of my voice, go ahead and just hit me with a chat real quick just so I can make sure that this is working, and then we'll get rolling. I think it's going. I don't know. I won't know until someone comments. Till then, we're just hanging in a room. Dr. Marcico, thank you very much. All right. So I guess we're off and running. Hey, Michelle, what's happening? Good to see you. All right, here we are. Kayla's in. Now we're running. Whoops. Dropping shoes everywhere. Chat. All right, so we're going to have some fun. We're going to take questions tonight. Hopefully they'll be useful. And then we're going to start off. We're going to bring her right in. We've got Dr. Kipros with us tonight. She's going to share a little case story. And we're going to let her go because she's got a little one too. So here she is.
Hello.
Good evening.
Good evening.
I thought we'd let you get running here and share this story. I know you're excited to do it, but I know you also have that little fella.
I do. He was almost on with us.
So cool. So if you want to in the chat, you guys can throw questions in there. We're going to talk about this little victory for one of our cases, and then we'll get to questions. So you want to get after it? I can turn it over to you.
Perfect. Yeah, I've got a cool case to share today, and I'm kind of going to walk through it a little bit beginning to end so people can kind of see the process and what we do with a patient when they come in the office. So I'm excited to share.
Cool. Well, I'll let you get to it. Did you want to share your screen?
Yes, I will. All
right. Oh, the biggest we got to upgrade. Back in. Okay, so here's the share screen. Okay, while you're talking, I'm going to mute, and I'll let you go to work here.
Sounds good. All right. You see my screen? Okay, perfect. Okay, so I want to talk through this case study. This patient was a 52-year-old female who came to see us, and the chief complaints are listed below. I think a lot of these will probably sound familiar to people who may be dealing with things like this as well, but she came in with like an overarching chief complaint of dysautonomia, symptoms of POTS, so high heart rate, and just like a difficult time being upright. A lot of feelings of disorientation, and that led her to doing a lot less in her day than she was used to doing. She had extreme fatigue and then post-exertional malaise. So anytime she exerted herself, it was just like hours, if not days, of fatigue after that. She, after this, had to actually take a leave from work, so she was no longer able to work. She started to experience headaches, migraines, and then just a lot of sensory overload. So sounds became a lot for her to process. She was using headphones. Lights became a lot. She would try to use sunglasses. When she had to be in busy spaces, it was really overwhelming. And then a lot of brain fog, slowed processing speed, hard to recall words, just putting sentences together seemed slower and not as accurate as she wanted. And then she also noted pressure behind the eyes, some visual disturbances, blurry vision, and then lots of color changes in her hands and feet. So when she came in, she had the purple hands and the purple feet that she'd been noticing for quite a long time. So we started working. Let's pull this up. And some of the major exam findings that we found with her was when we looked at the sensory system, so her ability to sense different stimuli that we used. She had less sensation in her hands and in her feet for pinwheel, or like a pain type sensation, as well as cold, so temperature differentiation in both her hands and her feet. And we also noticed that in her feet, she had a hard time localizing. So if we touched a toe, she couldn't exactly tell us which toe that was that we were touching. So then we went and looked at the cervical spine, and she had significantly reduced cervical ranges of motion, and then tests for thoracic outlet, which is a compression of artery, vein, and nerve that comes out of the neck right above the collarbone here, were positive for her as well. Balance wasn't great. That's something she'd also noticed just in her day-to-day life, that she was running into more walls, wasn't as keen on her feet as she would like to be. And so when we put her on the foam pad, she had a lot of sway before she was correcting back to midline. Looking at her eyes with the VOG testing, she had these things called square wave jerks. So instead of her eyes being able to be still on a target or smoothly following the target, she'd get these little extra blips of movement, telling us that the brain wasn't able to like come in and like suppress those. So she was having too much movement when she didn't want to have it. And then her visual reaction time was pretty slow. I'm going to pull down to the next slide here because I actually have her initial tilt test result. We've seen some of these on the lives before. So we know that when we start looking here at the perfusion, so the actual perfusion of blood to the brain, we're looking at the columns for left TCD, transcranial Doppler, and right. And then we're looking at the white columns as our baseline when the patient's laying down. And then the gray columns, where we're seeing the percentage, is when the patient's upright on that tilt. So we want that first minute to be above 90% of baseline, and then the subsequent minutes to be above 85. So we can see with these bolded numbers, she wasn't quite there. So she was falling into our category of the cerebral orthostatic hypoperfusion as well. So this patient came in, she spent a couple weeks with us in the clinic, and we worked through what we call like an immersive neurorehabilitation. So we started to address some of those findings that we had in our initial examination. So treatment for her, we did some manual therapies and mobilization focused on her cervical and thoracic spine. So giving her a little bit more feedback about where her head and neck is as it moves, and then also working to reduce some of those compressions that was coming through her neck. We worked on gaze stabilization exercises, whole body rotation, and then we used peripheral nerve stimulation. So where we're seeing some of those small nerve fiber changes, so she wasn't able to feel very great in her hands and her feet, we started to stimulate those using the peripheral nerve. And then a really awesome thing we used for her was actually the Neuro 20 suit. So there's a picture of it right here. It looks like a really cool wetsuit that the patient gets to put on, and we're able to control through a computer of input, basically like using a TENS or electrical stimulation over the large muscle groups of the legs, the arms, the abdomen, and the back. And we're able to set where we want to provide more sensory input through those muscle groups. So for our patients, like people who have the small fiber neuropathy, like this patient, or just patients where we're looking to say, like, how can we provide a bigger stimulus from the body up to the brain? This suit is a really cool option for us to be able to use, especially because this patient, one of her main things was just like being able to exercise or move without extreme fatigue. Using this made a huge difference for her. She was able to do the biking in the clinic using this with like very little increase in symptomatology and pretty good recovery after. And then eventually she was able to get up and actually walk around, go for walks, things like that using the suit. I think she loved it so much. I actually think she got one for home so she could keep making strides using that. And then we also did some therapeutic exercises. So once we got things stable and moving, we gave her some exercises that she could continue home to make sure we kept stability and motion in those areas. So here is re-examination. So at the end of her time, we were able to see some pretty cool objective improvements in the data that we measure. And then she was able to note some pretty cool subjective changes as well. So we noticed that she was much more sensitive to the pinwheel and temperature in her extremities, so she could actually sense them the way we wanted her to be able to do. She noticed that those extremities also had decreased stiffness, and the purple discoloration was way down. We saw objective and she noted subjective improvements in her cervical ranges of motion. She could actually turn her head without feeling stiff, sore, and feeling disoriented. And then we saw that those tests for thoracic outlet syndrome became negative. She reported decreased frequency of headaches. Then we look at her tilt table re-exam here. We're seeing way better levels of perfusion. This is in a couple weeks, so we really like to see these numbers pull up. We're like pretty close there. A couple spots in bold, we're a little bit under where we want it to be, but to see this in a re-exam in the time in the office is pretty darn cool. And then she also noted that during her time in the clinic, she was actually able to start going for walks in the evening with her partner, and then being able to like be upright and help to make dinner. For people who have been bed bound or couch bound or just being upright is hard, being able to help with things around the house like that is pretty heartwarming and awesome to see. And then she also reported that she had an increase in energy levels that she felt like she could actually sustain throughout the day with doing treatment and adding in some exercise in the evening. So she was a pretty awesome case, and we got to use some really awesome therapies with her. And she's been pretty successful at maintaining her progress in the clinic and just like keeping on going with it when she's been home. So just kind of wanted to walk through that about this awesome patient and kind of show you top to finish how we run through a case like this. So I'm gonna pop back, and there we go.
There you go. Very nice. Yeah, this was a really good one. And actually the numbers don't even do it justice compared to like the subjective part of how she felt. And from what I remember of that one, she was like way down and out, not working for quite a long time, not able to do very much at all, really like creating a lot of stress in their life, and being able to have them be able to get that partnership back was really cool. And she came, especially on the cerebral blood flow, it was kind of hard to see because it's small with that framing, but she came a long way in a short time and then just continued to do that home. So it's super cool. Just like what that little diligence was doing for her was amazing. So what she was able to do, I would say that like relative to a lot of people that came in, and you can tell me if you agree with this or not, was in like a very similar spot in terms of like maybe not thinking there was a ton of hope and just like, let's try it. And then ended up being in a really wonderful position. So thanks for sharing that one. That's a good one.
Yeah, of course.
Awesome. Are you going to hang out with the little one?
I am. I can hear some crying right now. So
Oh, it didn't even show through. Well, wonderful.
It might be time. So have fun with all the questions. I'm sure, as always, you're going to get awesome ones. And I will see you in the clinic tomorrow.
Sounds great. We'll see you then.
Okay.
All right, team. Yeah, that was a great one. I really like that case. Yeah, bed for 3 years. And that's like a no joke COVID bed for 3 years. Like just brutal, miserable, just kind of not doing much of anything. So, and she's wonderful. Husband's wonderful. It's really awesome to have, to get updates from them. So really cool. And we want to share that Neuro 20 story. You can see Nomad Over Normal said it's really cool, the experience with that. Thanks for saying that. It's a really great tool. It's one that's not super common, to be honest with you. The work they've done has been really useful, and we're really thankful for them partnering with us to kind of give us a quick road to using that tool before it was widely available. And it's been wonderful for the cases we use. So shout out to them, wishing them tons of success in finding ways to get that equipment to more and more people all the time. Cause it's been very useful for especially like our neuropathy cohorts are people that have small fiber that benefit from that stimulation into the body as a way to light up that parietal lobe in their brain. It's a really wonderful tool for that. So with that said, good evening. Good to see you guys. We're here. It's November. Michigan, we had a beautiful day today. We're in overtime here, getting nice days. We don't deserve them this time of year, but we're thrilled to have them. But let's get to work. Let's see. Oh, Matheson is wondering about, feel like my next best step would be to get the transcranial Doppler done. Struggling to address some of the concerns my family has with it. If I forward their concerns here, could you help me address them in plain English, not native speakers? Not also familiar with the terms we use. I can do my best. I'd have to take a look at the questions, but I could do my best. Kayla P. I think I called you K-Lap last week, which is fun. Is it okay to do a tilt test and a stress test with pending CSF leak diagnosis? Reason for the question is because cardiology wants me to make sure to continue with the test, but when I contacted the ENT, they had no restrictions. So that's a good question. So with the CSF leak, what you're worried about is you've got just a perforation in that dural system that holds it all in there. There's a pressure amount that comes with that that you want to make sure is reasonable. Too much pressure or alterations in the pressure can be symptomatic. Leaks are tough to find because it's usually just these little pinhole leaks. And actually, tilt table is one of the ways we discover that, because you can see what differences change without any muscle contraction in the body when we put you in different positions. Obviously, being able to look at that tilt table response helps with identifying if it's a leak or not. A lot of people, the CSF leak, the suspected leak, gets put on the list pretty early on, but you're not able to really diagnose it in a really great way unless we're looking at some opening pressures. So obviously you're going to talk to the physician, see what's comfortable for you. But a lot of times those two tests aren't tests that they necessarily would contraindicate for, but you just want to check and make sure. It's a really good question to ask. Generally speaking, though, is one that people can do and is actually useful. Even with suspected CSF leak, a lot of suspected leaks aren't actually leaks too. So just keep that in mind. Not medical advice, just sharing some thoughts. Lisa, so question. If someone comes into the clinic, do they have to be off meds to get a clear reading on the first test, or can you also come in when you're on multiple meds? It's a good question. We get that question quite a bit. We have to manage it both ways, right? So there's some people, you're on meds, there's a reason not to come off of them or a reason not to abstain for them for a period of time. And then we look at the tests. Typically, when you look at like the pure version of it is try to do it without medications. That's like how they're designed. That's how the research is conducted. So that's where the normative values come from. But if we do them with medications, then we're trying to make some inferences about what the medications are doing, and then how that might mean, or how that may be interplaying with what we're seeing in the study. We have done cases where we've done it on meds and then looked at it. Patient made a decision to try it again, a couple of weeks later without the medication. And we can see the difference. And sometimes it's surprising because the thing that you would expect the medication to do, it may or may not be doing the way you think it does. So it's actually really helpful. But people that travel tend to try to find, to come off of them and then be able to get a clearer look. But we manage it both ways all the time. It's just a question of what somebody's going through. Okay. I'm going to answer this one from Matheson. They fear functional neurology is mostly based on Professor Carrick's own personal philosophy rather than evidence-backed studies. It's not a conventional or as evidence-backed as more conventional concussion clinics. Is this true? Okay, so Professor Carrick is actually my mentor. And when you look at his work, one of the things that's brilliant about him is it's all based on research that anyone can find with a PubMed account. The difference is you just have to read it and then be willing to implement it and then be willing to go from there. The reason it's hard to do, quote, evidence-backed studies is because you're dealing with a patient population of people that you're trying not to fit in one bucket. So you're trying not to say, so when you run a research study, there's like, you have to submit it to a board ahead of time. And you have to say, like, here's the things we're going to do. Here's what we're going to test. What do you think? And so there's a lot of challenges to that, especially when you're doing case by case studies, when you're doing drug trials and placebo, nocebo, and trying to maintain equipoise. It's just a different game. But if you're in a clinic, in a private clinic, and you're more worried about the patient than the study, then it's really hard to try to fit everyone into the same box so they get the same research study. So the research is going to be less. You're going to be mostly case series. And if you look at these types of cases, that's probably the best and only way to present them, even though it's atypical. That's the deal. But to say it's personal philosophy is actually like, it shows a lack of understanding of what's going on, because there isn't really a philosophy to it. It's looking at neuroplasticity through what was published by Kendall and Schwartz, which was won a Nobel Prize for it. None of it is necessarily novel. It's all things that have existed before. They're just combined in different ways. And I think if you're looking for something that is different and that is a different amount, like outside of a conventional clinic, usually means you're looking for a different outcome. So if you're looking for a different outcome, you should probably be looking at the problem differently. And I don't know if conventional concussion clinics are probably the place for that. Many of them are actually kind of built on his work, trying to extrapolate it without being there. And that's a conversation for a different day. But hope that helps. All right, Dennis. What would be the best doctor to go to get a transcranial Doppler so it can be covered by insurance? I have no idea. I don't know that many people that do them to start with. So it'd be hard to point to one that's covered by insurance. I just don't have a good answer to that or where to point you to. Not that, and part of the problem is, maybe the important part is, the insurance is who's making whoever your insurance carrier is, the relationship is with the insurance carrier. So the decision not to pay for it is not really that of the doctor or the facility that you go to. It's of the insurance company. So the insurance company is saying like, well, we don't think it's valuable, so we don't want to pay for it because, they're really good at medicine. So that's actually the tough part, is not that people don't want to accept it. It's that they don't pay for it. So it's actually the insurance company that denies it, not the practitioner. So that's why it's harder. Jonathan Diaz, good to see you back. Let's see. I may have craniocervical instability. And what if ligaments are too lax and only produce only a procedure like the pickle are the way? If you have undiagnosed dysautonomia, would getting prolotherapy or even coming to the clinic? If I have dysautonomia, would shots be safe? It's not the vaccine fear. Okay, so we're getting a lot here, and I think we might have missed some words in this one. Okay, so the thing about craniocervical instability is, we should talk about this because it's been on my mind lately. So craniocervical instability implies, like, cranial is head, cervical is neck. So it's instability of the head on the neck, right? And then, so what are we classifying as craniocervical instability? This is really important because that is a term that gets used a ton, but it's very non-specific. So you talk about ligament laxity here, and then the question would be which ones, or which one, or in which direction, or which plane. So an injury that's in the alar ligaments is going to present differently than a problem with the anterior longitudinal ligament or the posterior longitudinal ligament or the transverse ligaments. So while it is useful to say, like, I think my head moves too wobbly on my neck, as far as trying to understand what to do about it, there really needs to be a better understanding of it. So using an anterior procedure like a pickle, where you're going to use prolotherapy or stem cells, basically as a way to hope that it tightens, is an option, but it would be hard to make a definitive statement on that, and whether or not it's affecting the autonomic outcomes without more data. So in other words, measuring laxity in the ligaments doesn't necessarily, you have to have a clinical correlate to show that moving through that extended range of motion actually yields the problem. So very often we're in a conventional system, we're really guilty of looking at imaging in a vacuum, where you're just looking at imaging and you're saying, we're going to make the diagnosis based on that. But all imaging requires a clinical correlate. And what that means is we should be able to say, if that is what is wrong, if we exacerbate that, if we move it into that position, it should make the symptoms you're describing worse. And if we correct for that, it should make the symptoms better. And so you need that clinical correlate to really be able to understand like how to best make that decision. We had the same conversation today with a case where we're looking at some disc bulging that's happening in the neck at the third and fourth segments, right? And then the question is, do we do something to, to surgically repair those discs? But the problem is not, so when we think about the third and fourth disc, you got some innervation that's going to the diaphragm. That's meaningful because it's going to help you breathe. And then it's going to go to some places up kind of in the neck and shoulder and head region to control some activity there. But the problem that we're having is actually one of being able to maintain arousal. So what we see is that in certain positions, you kind of start to pass out. And as you look at that deeper, that particular presentation is not actually from a problem at the C3-4 region. It's going to be relative to actually constricting the vasculature going into the brain. It kind of creates a choking scenario, and then they kind of get choked out, right? So the question is like, yes, that is a problem. But is it the problem that you're trying to solve? So if we're trying to solve the problem of we don't really like it when you pass out in certain positions, we're seeing that that is not a function of this lower C3, C4 injury. So the question is, we may want to do something that affects that at some point. That may help with some of the breathing component, may help with some of the some of the experiences you're having in your arms, let's say, or in your neck. But the problem that you're trying to solve immediately is the one where you're choking yourself off. So it's actually like, let's start there. And that one is available because when we look at it, the MRI shows the 3-4 lesions. So we say, well, maybe I can do surgery. And that's what happens for a lot of people. But in this case, we would be solving the wrong problem. And it would not be useful for what she's experiencing, what she's actually trying to solve. And so the thing I have held my tongue on a lot, but I'm less able to do so, is this idea of are we able to clinically correlate that by amending this system, by fixing this one problem, are we addressing the main complaint of the patient? And so that is like the next step. So we look at imaging, great, but we want to know, like, as we also look at the correlate clinically, do those things match? Are we solving a problem that's going to be useful in this direction? Or are we just solving a problem and hoping that it helps? And I think that maybe that's too nuanced, but I think it's a big deal. And I think that goes with this idea of the craniocervical instability diagnosis is not a full diagnosis, because with this, you should have like what ligaments are laxed and to what degrees. And that's probably in there. A lot of doctors do a really nice job at this, so I'm not being critical of them. But if we're going to talk about it, we need to talk about it in a way where it helps us dial into that, because then it helps you to be able to figure out if you're solving that if you should be solving that problem in that way or not. Cool. Awesome. That was a long one. Thanks for hanging with me. Sasha, 4,000 steps. Who got 4,000 steps? Cheryl? Cheryl, what do you got here? Thanks to the video and classes, I set a goal of 100 steps a day around the house. A few days later, 200. I got an alarm today that I'm at 4,000 steps around the house and the grocery store. That is amazing. Well done. Congratulations. Lots of claps. Hope everybody here is rooting for you here, because that is just awesome. Thanks for sharing that. That's awesome. Awesome. Okay. Aline says I'm not on YouTube. I hope I am. It might just be a different link. I changed the links. We were going to try this slick new thing where I was going to be able to bring on Dr. Kipros and do it all in 4K, because right now we're in 720 and I don't love it. I want to be in high definition. But it didn't work right. So we had to scramble at the last minute and go back to the old way. Anyway, back to questions. Tracy, thanks for saying that. It was a great recovery story. Sasha, always in. Sasha is wonderful. I love her in the chat. She should just stay in the chat all the time. Okay. Let's see. K-Lap. Let's see if I'm catching up. Oh. Appreciate my not medical advice last week with Spiral. Absolutely. That's what we're here for. Everybody's been through a tough time. It doesn't always come early for people. But they just happen, right? So we just try our best to be here for each other when they do happen. Try to learn as much as we can so we're prepared, so we can be helpful. And then this group of people is just wonderful. What I'm learning is that a lot of people that are new and trying to figure out what is going on don't even know what questions to ask. And we've been getting some really nice feedback that people appreciate what you guys are doing because you're asking the questions that they don't know to ask, and it helps them to like find their feet and catch up with where they are at a much faster rate. So I appreciate you very much for giving me this chance to try to interface and ask those questions and answer those questions, because it's not just helping you when you answer them, it's helping other people that are also trying to catch up and get it going too. So thank you guys very much. Juan, is there anybody that does it the way I do in Europe? There are some people there that are very talented. Nobody that does it the way I do it, because they're all I've stolen them and brought them to my clinic. They're my ninjas, so we keep them. But if you want, we can reach out. Dr. Ginny can maybe help you get in touch with a couple of people that we know over there and see if that's useful for you. Cam, could you touch on why the ANS can react so strongly to seemingly non-stressful situations, even when orthostatic positioning is taken out of the equation? Poor dampening of the alarm system. Is that what it is? For many people, so I don't want to overgeneralize this, but for many people, that's what it's become. So you kind of get a little bit of a habit over time where your body is used to reacting to things in a certain way. It's anticipating it. And it takes some time to be able to work through that anticipatory strategy. So this is where the self-talk matters. This is where like walking yourself through it matters. Being able to calm your breathing matters. So you're kind of like disengaging that alarm response. Some people react strongly because there's a stressor there that we're just not picking up on, and then we just kind of assume we're overreacting to something, but it's really our body reacting to something that we're not fully aware of. So those are both available, but especially once you see people starting to get stronger, but they're still feeling that in you. Some of that just takes a little bit of time where you're talking your body down and you're like, hey, we did it. Let's take the alarm level down a notch. I can remember, yeah, well, maybe I won't talk about that, but just, there are times when that old feeling pops in and it just kind of grabs you out of nowhere. And it's almost like it scares you and you feel all of that kind of well up again. It's particularly difficult in my perspective for people that have been going through autonomic problems, because they're so interwoven, meaning like the things that you really don't want to feel are like the things you feel with that level of like being alarmed or anxious or whatever that might be. So it takes you like full circle back into what you're trying to get away from. So it's like extra jarring versus if that's not the thing you're worried about and you notice like, ooh, I mean, my heart race a little bit, made me a little nervous. That's, ooh, I don't like that. But it doesn't feel as as difficult as it might if that's the thing that you had been feeling you've gotten away from, or you have moments where it's not that and then you feel it come back, then it's extra scary. So exactly what you're saying, poor dampening the alarm system. So we want to use exposure to that. But then also for some people, it's using those frontal feedback mechanisms to get better at dampening it back down again. Great question, as always. So John, this is a good question. If you have dysautonomia, would shots be safe? It's not the vaccine fear. So to the degree that they're safe for anyone, again, not medical advice. I'm not giving shots. I don't have the ability to tell you to get shots or not. But a thing that's interesting to think about is some people, if they're reactive, I don't know if this is the question you're asking or not. So some people that have had injuries related to iatrogenic causes, this is the way we say like shots or vaccines or anything like chemical medication, stuff like that, right? So when we've had a reaction to that, sometimes within vaccines, people have reactions to the adjuvant. It's another conversation from today. The adjuvant in a vaccine is the thing that like kind of kicks the hornet's nest. It wakes up your immune system and says, hey, pay attention to this. It's like, in Jurassic Park when they wave at the dinosaur and are like, follow me. That's the adjuvant. But some people are reactive to that because their job is to stir up your immune system a little bit. And so, but once you become reactive to that, then the question is like, do you have potential to be reactive to it again in the future? And so those are the cases where we have to think about that and think about what are the best ways to approach this. What is the kind of the cost benefit analysis? Great thing to talk to your GP about if they're opening to talk about it. And anything that's going to obviously be a catalyst to an immune response when we have dysautonomia. We just want to be aware of what we're getting into with that, because if we have a hyperkinetic response already, hypersensitive response already, then we might get a more robust response to that immunological stimulus. And we just want to kind of be aware of what we're getting into. So it's not saying you should, it's not saying you shouldn't. It just helps you work through the problem and like how you could think about how to do that. What is the cost and what is the benefit? And then trying to, make a good decision from there. Cool. Oh, love your work. Thank you. Thank you. Ooh, how do I say? Thundamari. I don't know if that's right. I like it. If it is, oh, we got a note as well. 2 years in bed post C, even when lying down, feeling lightheaded, nauseous, fatigued. Symptoms will go away for weeks at a time. That's cool. What explains this? Blood pressure drops when standing. Managed with meds, but no change in symptoms. It's a really interesting question because obviously this is a constellation that we see quite a bit. This is a symptom constellation that is pretty common, but I'd be hesitant to try to say what it is without observing what's going on and being able to measure some things. But how could we start to think about that without trying to go too far? Because I want to help. Man, so there's so many things I want to check. Maybe I'll talk about it that way. We'll talk about things I'd want to know. So I am very interested in this part where it talks about blood pressure dropping when you're standing. That's really interesting because it means that whatever's going on in that feedback loop is not kicking in. And then when I think about laying down lightheadedness, I want to know how that correlates with the blood pressure side. The nausea is also a thing that is going to be very interesting there because we want to see how are you able to transmit through those baroreceptor systems, and is the sensitivity changed, and do you see that translating into feedback into the NTS, and then how does that correlate with activity in the cerebellum, and then looking at peripheral nerves from there. So you're kind of like winding through this web. It's almost like if you got a bunch of cords that are all tangled up, you're kind of taking them apart and stripping them out so you can see where everything lies, and it gives you a lay of the land. So I don't have like a wonderful easy answer for you here, but you would want to look at where these things all start to correlate to each other from a control systems perspective. That's what I would do. And then from there, then to look at triangulating where might you be able to have an input on that system, especially if management with medications isn't solving it. It means that there's enough feedback loop available it's not addressing the underlying. So I'd love to be more help, but I just don't know enough, and I don't want to try to overcorrect here. Okay. Yeah. So just skipping over this for a second. Which root cause can be intermittent and not always positionally related? These are wonderful questions. And positionally related, though, doesn't necessarily mean laying down versus standing up. This can be positions of trunk position, head and neck position, pelvic position. So you don't want to you don't want to like skip over those things too much, but that's a really good question. Man, I'd like to know more. Okay. Jonathan, I'm going to go back. Jeannie, I'm going to go back to using this the way I'm supposed to, so I can see the comments at the same time. Where am I at? 1 second. Okay, can an atlas misalignment be the cause of dysautonomia? I've heard patients recovering from procedures. I just don't want to die a slow death with the issue. I get it. I mean, that's the fear for all of us and all of these things. So could it be an atlas misalignment? It can be, for sure. And this is kind of along the lines of your questions around CCI, looking at the neck. I think there's another one here that I just saw asking about Fat Matt. Good to see Fat Matt. How do you feel about the surgical procedures? So all of those things kind of come around to maybe thinking about in that upper cervical segment. First off, can that yield autonomic symptoms? It very much can, because of the things you're transmitting through your neck. So you've got blood vessels, you got a carotid artery that are traveling up into your brain, fueling your brain. That's a big deal. You've got the internal jugular vein that's draining your brain. Also a big deal. One on either side, right? Both of these, this is all happening bilaterally. But then you've got also the outputs of the sympathetic chain, right, that are going to come up through here as well. And then you got the vagus nerve that's going through here as well, that's carrying sensory information from your heart, your lungs, your gut on up. And then also a little bit of a signal that's going down to your heart, to your voice box as well. So like all that stuff is traveling just on the outsides here. And then additionally, you got the spinal cord that's running up through the middle. And when we do things that irritate the back part of the spinal cord, irritate where the disc tends to, to compress against the cord, then we also see autonomic symptoms that can be progressive from there, because we're impairing the autonomic signal coming down on the motor side. So when you realize that upper segment, the reason it's so well talked about is because the positioning and movement of it is so vital to making sure that you can get all of that stuff through unimpeded, so that you're not taking that little hole between the segments and shearing it smaller, right? And so that part becomes really important. And the same thing in the vertebral arteries in the back, because over the transverse process, sometimes people have little different anomalies that grow, and they can restrict the flow through the vertebral arteries up as well. So that top segment matters a lot, because it's the last stop that allows for kind of irritation in those systems that are going into the brain and then coming back out. So then then you're moving from that, and then you're thinking about, well, is it moving too much? Is it moving not enough? Is it stuck? Is it dyskinetic, which means it doesn't move the way it should? So in that sense, then that's the first thing you're trying to solve, is like, is that positioning or the movement of the neck? So is it positional? Is it movement related? Is it at extreme angles? Is it while you're sleeping? What's going on? And then you're thinking about, well, how do you solve for that? Traditionally, the way you think about solving it is you start from the most conservative things, which are the things that have the least potential long-term negative impact, to the things that become more invasive and could potentially cause that are you'd say they're more risky, right? So they have more probability associated with a negative outcome with them. And so you typically move up the chain depending on what do we think is going to solve the problem the best in the most conservative way. And then we go, obviously, toward more risky ways. So things like manual therapy, PT, things that affect our ability to be able to just control that movement first, using a chiropractor, using the PT to be able to get the motion correct. Those are like the least invasive ways. You're not cutting anything open. The downsides are really low, and they could potentially carry high upsides. And if those aren't effective, or those are not going to be sufficient, then you start looking at more invasive things. And obviously, anytime you get the knife out, there's a risk to that. But sometimes that is the only thing that's available for people. So on a case-by-case basis, you're trying to basically figure out how likely are you to have success conservatively? What is the risk you run? And then progressively looking at the more and more complex and invasive procedures from there. So I think that hopefully answers. There's a few questions around CCI, a few questions around that. I find a lot of people respond really well to inputs. So like how your brain is actually controlling that movement is really important. People get injuries, they get headaches, or excuse me, they get car accidents, they fall off stuff, they get hit by stuff, they get hit by other people, they get hit by themselves, and create these different orientations of the neck. But so many of them are responsive if your brain can learn how to control them again. We just don't learn how to do that great, because usually we just think, I had a little stiff neck, but I'm coming out of it and I'm doing okay. So things to consider, I guess. I covered a lot of different ground there. So let's see where we are. So inevitably we get into this question. Saw one video on Shorts talking about chiropractors causing dissections. I think it depends on chiropractors and patients with weak tissue. Could that be true? Yeah, so this was a thing for a little while where they looked at these studies where, using adjustments of the neck where you're more likely to cause injuries. Turns out you're equally as likely to cause an injury turning your head to look, check your blind spot in the car. For those of you that do that, you got fancy cameras, you don't have to anymore. If you're in the hairdresser and you tip your head back in the bowl, likely to have them there. These are talking specifically about vertebral artery dissections primarily. And when you look at the segment of where the vertebral artery dissects, it typically dissects actually within the skull. And so obviously the tension you're putting on that with an adjustment is not likely to cause that. The risk is super low. So one of the ways that is often expressed in that is if you look at the cost of chiropractic malpractice insurance is so low because the incidence per adjustment is so low relative to something like surgical complications or medication complications. So just a thing to think about. Is there a risk? There's always a risk for sure. And that's just part of the game. It's like anytime anything happens in your life, there's a risk to it. But to be worried about going to the chiropractor because you're worried about them causing a vessel dissection might not be a well-founded worry for most people. But talk to them about it. Talk to your doctor about it. I'm not giving you advice on it, but you can look up the studies, throw it in ChatGPT. You realize that the risk and likelihood is similar to basically anything that causes you to turn your neck to a significant degree. Most of you sleeping on your stomach, sleeping on your side, you get to the same place anyway. Okay. Well, let's be done with that. Where are we? Okay. Let's make sure. Yeah, I'm going to make sure we're I know there's a lot of specific questions, and I get the impulse to ask and answer, try to get answers to specific questions. But remember, I can't give you much as far as like what the problem is without an exam, without a proper workup. So just keep that in mind. So I can't give advice on super intricate things like that, but I'm certainly open to trying to help at least provide like how I might think about a thing. Cool. All right, Michelle. What's up, Michelle? She wants to know, can you help us understand why the middle cerebral artery is measured and not the posterior cerebral artery? I have a very easy answer for you on that one. So the reason that the middle cerebral is measured is because, number one, it is the first branch off the carotid. So as it comes up, it's pretty thick. And it just so happens like where that comes up happens to be where you can reach it through this thin part of your skull right here. So this, they call it the temporal window. So the temporal bone, or in your temple, it's, the bone is actually a little bit thinner there. So it's easier to shine the ultrasound through it. And because of that, you can aim it right at the middle cerebral artery. It's kismet. It just is great that it happens to be kind of the main trunk going up. So it's going to affect, kind of this territory and then the anterior territory that comes up and then goes through like a mohawk. So it's really helpful to be able to get just a sense of the speed of the flow that's coming through. Obviously, it's not giving you the nuance of like the control systems everywhere. But so you're kind of limited by those things. You can look at the vertebral artery in the back and you can kind of tip it down and look at the posterior as well, but the window's not as clean. But the posterior artery and the other arteries are going to be derivative of the overall anterior and posterior circulation. It's really nice to look at the vertebral arteries, but it's a little bit harder to do that on a tilt test because of where they would have to sit here on the back of your neck and the likelihood that people knock them around and then you lose the signal. I mean, ideally, we would love to be able to get the posterior and the anterior, and we've been working with our equipment provider to try to figure that problem out. But right now, being able to, ultrasound is super sensitive. So if you're laying someone down, obviously, if you got two probes back there, it's really hard to get them to not move. And plus you got to deal with hair and all those things. So, but we're working on that, which would be super, super cool if that came through. So if anybody's got any ideas, Corey, maybe you're out there, fix that up too. Corey's my go-to, just anything that I want to invent. I just tell Corey, let's do it. And then I just wait, see what happens. Okay. So another potential family concern, I don't even know how to address these. I'm sorry. That a functional neurologist tries to treat a lot of systems, whereas some more conventional clinics may have several specialists who can work in a team for each patient. I feel that surely it must be better to have a team of specialists, one vestibular, one cardio, one medical doctor, et cetera, rather than one practitioner trying to cover it all. I mean, that's your prerogative. If that's what you think is better, you should do that for sure. I wouldn't argue with you. But also those are all people that are trying to solve one problem by, eating their elephant from their angle, right? So what's really important is understanding how that vestibular system coordinates with the cardiac system so you can understand how they work together. If you're just moving from station to station in silos, and that's actually a terrible way to do it because you don't understand how they're working together. But obviously, more people that you can get eyes on you, the better. We run a team, so I'm not criticizing that at all. We run a team, but everybody has training in all of it, and that helps everybody to be redundant so that more brains are processing the same information so that they're able to look at it in a bigger picture. I think that if you have one brain that can see the whole picture and get it done right, then it doesn't matter. So there's plenty of people that practice as one person that just know what to do. So I don't understand these. These are just kind of things that you might think of as probably a way to be. I mean, you should just try it. Go to the regular one. If it doesn't work, then go to somebody that can help. Okay. Do you have any more book recommendations? I've read both of Dr. Deutsch's books after your recommendation. Cool. Want to learn more? Ooh. Book recommendations about the brain. Depends on which way you want to go with it. So my life tends to be more textbooky, and for better or worse. Let's think. But if you're interested in just kind of like contemporary neuroscience stuff, all the old Oliver Sacks stuff is really good. He's a good writer, and he just talks about more of kind of the interesting portions of those cases. Man, you caught me off guard. I don't know. I tend to be more in the textbooks. I really like my Kendall and Schwartz, Principles of Neuroscience. Marsden's Movement Disorders is amazing. Novak's book on autonomic systems is amazing. It's amazing to me that he's the only MD that's kind of really thinking that way, but like for way longer than it's reasonable that nobody else even copycatted him. So he's great. Tons of papers. There's some really good books about the cerebellum that I think really tie in a lot of integration for people to try to understand how you take the different silos we just talked about and think about them as a unified network. So anyway, Nathan's camera. Any MCAS tips? Well, make sure that it's pathological to histamine first, and it's not a higher order central processing error. That's probably my biggest tip, because I think a lot of people are trying to solve an end order problem by dumping in lots of things to inhibit histamine when it's just doing that because the feedback loop is broken. It's being told to produce more histamine. So that would be my kind of biggest tip, is make sure that that's what you know. Gino, what's happening? Hope you're doing well, man. Have you heard of studies on nicotine having benefits, especially regarding spike proteins and neurological function? I have read those. And it's tough because there's definitely some things that point to nicotine having some benefit in certain ways for people, affecting nicotinic receptors, if that's kind of the variable. And then there's also some that are like, oh, it feels like it might be good. And you're like, I don't know if that's that useful. So mostly that's been done, my opinion, maybe. A lot of trial and error and just kind of winging it, 2 weeks of intense nicotine and seeing how people do. And that's how they've been approaching it. But with that said, we've heard anecdotes of people that like it, but some people that really, really don't. And kind of at this point, it's kind of like when other things come out, like when cannabis became legal. I remember when they legalized cannabis, there was like a flood where it was like cannabis fixes everything. And it was like there wasn't a thing you could have in the world that being able to get your hands on some gummies didn't fix. And so in that time frame, though, you're just kind of like, I don't know. There's not like we don't have enough information to be able to say yes or no, other than like, if you want to try it, go ahead, try it and see. And I think that the nicotine studies are kind of the same way right now, because for so long they were tied to cigarette smoking and then all the negatives that came with cigarette smoking, et cetera, or even just like chewing tobacco usage and all of that. So I think we're still on the front end of understanding where the lines are with nicotine. So like what things it's actually really good at and which things it's not as good at. But I think that information will come, and my personal perspective on it is like, I think there will probably be things that it's actually really useful for. And I think there's some things that we maybe thought it might be useful for, but it didn't pan out the way we wanted to. So I would have a hard time making a recommendation on it, but you can definitely keep reading. There's stuff that keeps coming out about it. It was a couple years ago when they were doing the nicotine patch studies, particularly with long COVID, which is I think what you're after. And they were kind of like equivocal, where they felt like in some people it might have been a big deal, but in some people it didn't. And that may be more akin to loading up the nicotinic receptors within that autonomic system and like kind of like flooding the zone. But if the system works and that's not the problem, all of those systems will downregulate and they'll normalize the nicotine, and then it won't work anymore. So if that's the true problem, then it'll keep working. But if it's not, and you're just like flooding the zone, you see what happens. But if that feedback loop is maintained and that part actually works, then it won't continue, and then you'll know, and then you got to solve a problem upstream from that. So, but hope that helps. Good to see you, man. All right. Dr. Marcico said lots of great questions. I agree with that. It is. It's really good. Covering a lot of angles. Principles of autonomic neurology is a place to start. I like that. It's good. Michelle's just being sweet. I trade in my 11 doctors for one Dr. Keiser. That's very kind of you to say. Okay. We got some of the questions here. I'll try to do that. John Chung, tuning in from the Detroit airport en route to Chicago. You should have swung in. We got a seat here for you. Hope you're not stranded in the airport. I know that's been tricky lately, but I hope you're doing great, man. And I hope whatever you're doing in Chicago, I hope it's a lot of fun. Michelle says, I never heard anybody suggest ChatGPT. I'm here for it. Although I do think They mentioned this week that they're no longer gonna give medical information, which I think is too bad because you know, for like getting your head around stuff, for a lot of people, this is useful. But that's where we're at. So we'll see if it comes back. But for a lot of people, just to like get your basics on understanding what's going on and be able to synthesize some information, know which questions to ask, I think it's a great tool. I think it cuts down a lot of like the learning curve for people. So rather than the doctor being the gatekeeper to all of the information, you at least get access to like to get started and then start to learn like which questions should I even start asking, and then using the doctor as a way to use like the art and expertise of like the practice of what they're doing. That's a really good combination. I actually like that marriage a lot, but we'll see. Okay, a lot of questions. I'll get back to them. I'll get back to it. So our last question was about nicotine. I'm just going to take this one because I think it's relative to it. He said that nicotine raises my heart rate by a ton, and it can. I only smoke sometimes at night. When I'm standing during the day, it's like 90 to 100. When I smoke, it goes to 125, 130 when standing. So that's not ideal, right? So for you, Andrea, makes sense not to do it. But that's a good anecdote for people that are dealing with that tachycardia part. So appreciate it. Appreciate it. Brittany, since 2021, Tacky and Brady, hypotension, arrhythmia, dizziness, vestibular migraine, ringing in the ears, no diagnosis. Tilt and autonomic testing are normal. Treated as dysautonomia, but no relief. Any ideas or thoughts? We'll give you some thoughts. So if we're looking at like tachycardia and bradycardia, so this is like high heart rate and low heart rate, as well as hypotension and arrhythmia, all of these things are kind of talking about this inability to be able to manage just a normalized state, right? So if we're trying to keep a line like this, but we see that it has a lot of variability around it, then it would mean the things that would normally detect how to hold it in are not holding in as well as they should be. So the sensitivity of that system to fix itself, to create the gain is going to be impaired if we're seeing these big fluctuations. And that's whether that's tachyarrhythmia, bradyarrhythmia, looking at hypotension. That hypotension can sometimes happen because as we get the arrhythmias, so your heart's beating out of rhythm, it means that you're not going to have a ton of like oomph when we're driving that heart rate, and so the blood pressure may be lower because the inefficiency that's created in the heart. So for a lot of people, I'm assuming if we done diagnostic testing, or no, maybe not, or you said they're normal, cardiovascularly, we kind of want to understand that arrhythmia a little bit and to what degree that plays a role. And then looking at, so these are cardio and vascular related concerns largely here. So you want to look at, if it's treated as dysautonomia, that kind of speaks to the fact that maybe it's autonomic systems that affect more than one system. Like we're talking specifically about the cardiac and vascular system here. But we want to make sure that it's like what's happening with the gut. What's happening? Is this distributing or bleeding into other systems? Or is it something that is specific to that cardio and vascular regulation? And so that's a good place to start. You've heard people talk about some of the other testing, looking at CT angiograms, looking at ultrasounds so that you can see if everything's transmitting the way it should. Are we having anything that's compressing on the way to the heart? Kind of working from the heart and out might make sense if we're having an arrhythmia, just because that arrhythmia can be such a struggle with being able to generate enough force to push blood everywhere and do all those things. So that's probably a good place to get more information. But definitely there's more testing that can be done to erase some of these question marks and get you dialed into a little bit more of a nuanced problem to solve here. So I'm rooting for you because I know this sucks. Don't give up hope on it. Let's learn some more and figure out like what is the problem we need to be solving. And then let's get after it like crazy people. I don't know who this one is from. It says, related to a previous question, why does the anxiety seem to present physically, but I don't feel anxious from a psychological perspective? That happens all the time, especially if it's being originated from the body, kind of sending a signal to the brain, like we should be worried about this. A lot of people will feel like, I feel like my body is anxious, but without me, like it's not bringing me along for the ride. So I have all the sensations of being anxious, but I'm not feeling anxious in my mind. And those are, in my view, it's an indicator to try to look and understand physiologically what's switching in error and what is my body trying to tell me when that happens. And I find that to be really useful. Jonathan Diaz, do I do digital motion exercises? I don't. We send them to, there are a couple people nearby, or we'll try to send people to wherever they're from and find somebody near them to do digital motion if we want to do digital motion or doing other types of positional imaging. Cheryl, my father doesn't believe in, quote unquote, alternative medicine. Can you please explain the roots of traditional medicine in America? So, history lesson time. Okay. Oh, it's not particularly a popular opinion, but when we think about medical practice as it exists today, it is a function of curricula that were developed like in the post-Rockefeller era, where a lot of the medical curriculum is kind of based on inputs from that system. And better or worse, there's some things that medicine does really wonderful at, and there are some things where they're just not as specialized in, or they're not as concerned about. It's largely based on allopathy. Ideas behind allopathy are basically, to sum it up, when you have a problem, you're trying to artificially stop the problem so that the body is not having to respond to it. So you're kind of like stopping what the body's trying to do to solve a problem. If you got a fever, rather than let the fever go high so they can kill whatever's inside, you stop it so that it doesn't, cause a problem. And there are things that's really good for. When you look at alternative medicines or alternative industries, they've been around similar periods of time, sometimes longer, but they did not have the same backing. And there's lots of fun stuff you learn about in chiropractic. Chiropractors were they had a rough go, and in turn of the century, 1900s, a lot of them were attacked for practicing medicine without a license. They were like, "Yo, I'm not trying to practice medicine," and so there was this legal framework where there were some ways to try to establish medicine first, and then to be able to kind of run everybody else out. They absorbed the osteopathic profession into medicine as a way to kind of quell that. Osteopaths were brilliant strategies, largely around manipulation and more kind of natural types of things. We could go a long time into that, but it's definitely an interesting read if you or you can type into YouTube and search about that. And that might give you some insight into why things are done the way they are now, and why alternative medicine isn't regular medicine. We don't want to be medicine. We want to be what we are. But some good branding that goes with that. So it's what it is. But I think people with more access to information, more access to they're developing their own expertise. Having a personal expertise has been really helpful, because there's not just the gatekeeping of going to the physician like there used to be. So people can get a more distributed view of what their options are, which I think is really useful. Robin, with some POTS and dysautonomia occurring due to vax injury, is there any good guidance or resources discussing ways to naturally detox? For example, consumptions of certain vitamins and minerals like zinc. Yeah, there are a couple protocols that have been developed that you can search for, using some simple things, using nattokinase, using turmeric, using some different kind of things that would typically be anti-inflammatory. Who had the protocol? Ginia, help me out. I don't know why I'm blanking on the name, but they did a protocol they're studying. That seems to be the one that people are the most interested in at the moment. I don't know why it's not coming to mind. Ginny will throw it in there. She'll remember. But yeah, they're definitely, most of the stuff that's in it, I have it written down. We've used it with different people. Is pretty stable, solid stuff. Nothing that's going to be too crazy. And it's worth doing. So Ginny will throw it in there for me, and then she can help you out. Cheryl asks, why is there so little knowledge in the traditional medical community about autonomic dysfunction? Some people know a lot about it. It's more in the application of how we think about solving it. It's just kind of a one-way ratchet. But I do think there are people that do know about it. I just think that the people that are kind of like the top of the funnel where everybody goes in, they just have to know such a broad amount of things that it's kind of like a mile wide and inch deep, where you just can't learn it all. And then we're trying to get, they're trying to shuttle people to the right places, and they may or may not be as focused on those things, because autonomic dysfunction is largely neurological, but it's neurological in a way that's integrative, meaning it's not like one area of the brain blew out and it's got a big stroke in it. It's more with how all these systems are interacting with each other. And there's just not, that's not been the way it's taught traditionally in the world, is to think about how things are interactive. So everybody's still playing catch up on that end. Yeah, Jonathan was asking, he's curious about if COVID unleashed CCI issues for people, tissue damage, especially when it comes to EDS people. I don't know the answer to that. That's a good question. And we're learning that right now, because sometimes we don't know like what was there before. That's part of the tough part is, so some people will have older stuff, and it's not just specific to COVID. It can be other things as well. But you can see where they've got these old neck things, but they kind of do okay. And then there's another catalyst that comes along. Things really start to go off the rails. And then from that point, we see the symptoms. But when looking back on it, there's kind of like there were clues before. So we'll learn that more as we get more front end testing that we can compare, like before and afters. It's really hard without a before and after to know what things were like before versus secondary to it. So anyway, sorry, I'm writing to Virginia real quick. Okay. New Wave Brazil. I like that name. Hang on, I still got that. I still have Gino's question up. There we go. Can cervical proprioception ever improve the feeling of upper cervical instability? I would say emphatically yes. It is one of the things it's one of the ways that I think is the most effective ways to resolve this. So let's say you've got ligament laxity. So a ligament is like the hard end range, right? So we talk about the dog on the chain, right? The ligament is the chain. So when that dog runs, gets snapped by that chain, that's the ligament. So it's protecting the end range of motion. But most people don't operate at the end range of motion as their normal movement pattern. So in order to stress and strain that ligamentous system, we have to have muscles that aren't able to engage well enough to be able to maintain that position. So proprioception allows you to be able to know where I am in space in a way that controls the movement so that I'm not pulling taut on those ligaments in the first place. Now, does that mean I have the potential to still go farther if my muscles will allow me? Absolutely. But if I have better proprioception, the time spent there, or the likelihood of going there can decrease. And I would also add that we should not discount the fact that in some people that instability, or a better way to put it would be hypermobility. I think that's really where we're at with most people, is just we have an increased range of motion, can come to be because we have a decreased range of motion in other parts of the spinal movement, particularly lower in the cervical thoracic area. So if I get stiff in other parts of my neck, I can make up for that stiffness by increasing the motion available at the upper segments. And so there's actually a really nice paper, and I'm struggling with names tonight. But there's a nice paper that kind of looked at this with people that had lower cervical rigidity and then had developed secondary upper cervical hypermobility. And then when you improve the lower cervical mobility, we actually see improvements in the hypermobility in the upper cervical area. So I think that's super important, and I wouldn't sleep on that as a concept. So, okay, give me 1 second. Okay. Boop. All right, here we go. Okay, Jonathan asking more questions about the neck. If you got hyperpots, for sure can happen from the neck as well, but we don't know if that's precisely what to do it. How would you, what is the approach to reduce sustaining blood pressure issues? You got to know why it's happening. Is it proprioceptive? Are you constricting something? Is it the neck to start with? So there's where we got to start getting into more information about what is unique to that particular person. Yeah. Let's see. Where were we here? Oh, I've been super active in the chat. You guys have so many great questions. He's trying to keep up. Dr. K mentioned a protocol. Give me 1 second. Let me take a deep breath. I think it's McCullough. I think it's Peter McCullough. So look up the McCullough. It's OUGH at the end. He's got a protocol. Pretty sure that's who it is. And I'm blanking on what all's in it, but we have it written on a nice little card at the clinic. And we don't use it as much anymore. But it was super common. We were using it, in like 21, 22, 23, quite a bit. So that's why it's not as sharp on my old mind here. But I think it's Peter McCullough's. You can look him up, and then I'm sure that he's got that's all published. It's all public. You can go nuts looking at that. Sorry, I couldn't come up with that at first. Yeah. So I'm going to say for Jonathan, yeah, I want to answer this question, but I don't know how, because I don't know enough about what's going on. I'm sorry. Here's where we got to start getting into diagnosis to get into any real nuance with that. Okay. Cheryl, good question. Can a sludgy lymphatic system start moving normally again, or do some systems always need assistance? I think most cases, I would say, in the bell curve, most people can actually resolve that pretty well. There's a lot of Ayurvedic medicine, a lot of Chinese medicine is really focused on that. A lot of massage therapy is focused on that. And I think it's a good place to look for a lot of people, but being able to have both the chemistry correct and then also the motility correct to keep that system moving and draining. But for sure, I would not lose hope on that. I think that's something that's available for more often than not. Bits and Pieces Studio, like that. Do imbalances like in hormones like estrogen, spelled with the O, so you're probably from across the pond, love it, and progesterone have any correlation to flares and POTS and MCAS? For sure. Yeah, we really want to pay attention to those, especially as you're cycling through and when there's a correlate. Alterations in those systems, especially if we're having a hard time with the feedback, are going to be more likely to produce, stressors on the body, which therefore can make people experience an exacerbation of symptoms for sure. So definitely part of the picture, not always the whole picture. If we could just solve that and it would fix everything, that would be wonderful. It's just not always the case, but it's always part of the picture that we're looking at. Nicholas, good to see you, man. Hey, Once cerebral blood flow / neurovascular coupling, ETCO2 stability, et cetera, improves, what systems usually lag the longest? Vascular, peripheral nerves, neural timing, et cetera. Do these things just catch up? That's a great question. And unfortunately, I don't have a great answer for it because it's going to be different depending on what the particular problem is. We want to see them kind of start to trend toward each other so that you can do more complex activities and be able to learn in that task specific manner again. So as far as like who wins in the race, it's different in different people. It depends on to what degree they're affected. Matheson, I'm taking these ones not so much because I want to answer your parents' questions, but I do think it's useful actually because a lot of people are also probably trying to answer these questions in their lives. So it's useful. I've told my family that I've only been able to find your clinic who can check me for both cerebral hyperperfusion and also neck obstruction to blood flow, but they ask how come I can only find one clinic who can do both of these things? Is that transcranial Doppler is so crucial? And if so, why don't more doctors have it? Great question. That's why we are here. It shouldn't be just one clinic doing it, but it's where we're at, and we're trying to make it not that. So take that for what you will. If there are other clinics, I may just not know about them. They may just be different. Certainly open to the idea, and I hope that more people are. I just don't know. I wouldn't know who to send you to. So I'm sorry. Let's try to get more. Nicholas, notice that my ETCO2. Oh, nice job putting that little 2 in the chat. How do you do that? You got some special keyboard work you do to get that? That's nice. Anyway, I digress. I've noticed that as my ETCO2 and cardio capacity improve, my visual exercises are more stable. That's fantastic. How do you separate what is caused from neurotraining from secondary benefit of improved circulation? That's the hard part, right? So when people have, and this is a great point. So when you've got impaired circulation, it makes the whole machine run a little slower. So it's hard for people to discern which symptoms are from the lower perfusion versus which ones are from an error in the system. That's why we spend so much time talking about the perfusion, because we want that to be rocking and rolling to the best of its ability, because you need that to run the brain. Then we can understand which things are actually problems within different pathways within the brain, and we can attack those. But it doesn't make sense to try to attack those if we have poor perfusion systems to start with. So this is like a thing that is so important to me, because when I started in this field, I didn't really think about the perfusion, to be honest with you. I thought about metabolic capacity. I thought about if this is too much for that pathway. But I, at that point, didn't really understand, like, well, remember, there's all these reflexes that make that system run. So if they don't work right, I'm never going to be able to get that. I'm never going to be able to get that metabolic capacity where I want it. I may be able to like gut it out and get it better over time, but to be able to have the underlying reflexes work, make it so that you know that you're getting enough perfusion into the system so that you can start to exercise it again. And here you're seeing just getting the perfusion in can be enough to start to let that system run. And remember, your brain, I get fired up about this part. Your brain's job is to learn. So it's going to try to get better. It's going to try to do things even better. So if we're sluggish on a thing, but we can start to feed it again, we can get the neurons to run again, we can get them to build those, build their plasticity, build that muscle and integrity back into the system, then they'll start working better. So we're not like trying to build it out of the ether. Your brain is geared to try to figure out how to make all these things work. And sometimes you just need to create the right environment for it to start to do that. And I think that message is so understated, so powerful, and so available that we cannot forget about it and let that sense of vulnerability take over for the sense of amazement about what your brain can do. So don't forget that part. Thank you, Nicholas. That's a great share. All right. So Nicole asks, what about vascular EDS with slow digestion, bloating, and pain? I don't know for sure how to answer it. What about it? Vascular EDS, if you've got it, means that we've got some impairment in the quality of the vascular walls. We want to be super aware of that, be careful with that. How does that relate to slow digestion, bloating, and pain? It's hard to know specifically because we don't know if it's directly correlated to the vascular system or if it's a different problem. So that's where we gotta spend some time, learn some more. Why do patients get enlarged jugular veins in dysautonomia? Not everybody does, but sometimes that enlargement in the jugular vein can come from an increase in pressure. Veins are pretty thin-walled. They don't have a lot of muscle in them. So if we get a backup of pressure, it's going to balloon out a little bit, which is helpful when we're looking at imaging because you can see where the constrictions can be. But yeah, it mostly just from a backup. It just becomes a basin, becomes a sink. It's a good question, but not everybody gets that. So make sure when we're like dysautonomia implies that it is within the autonomic system of the body. So it's a neurological component. And from there, we want to back out into, is it the whole autonomic system? Is it a portion of it? How do we talk about that? Away we go. Cool. Whew. I need a drink of water. I feel I've been talking a lot. How are we doing out there, team? Hopefully getting some good thoughts, some good questions today. Maybe thinking about some new things, good topics. I think I'm getting the sense, Nomad Over Normal, that the video that was published this week about some of the CCI stuff that we've been looking at seems to have maybe rung a little bit of a chord, and maybe that's spurring some of the conversation. So I think it's a really good conversation to have. I am usually a little bit reserved on the topic because there's just so many ways. There's so many different ways it presents that I'm trying really hard not to overgeneralize. Yeah, because the way it shows up is so different in different people, but also in ways that it can be very amenable for a lot of people, which is really exciting. So I want to share it, but then I want to make sure I share it in a way where we don't over condense people into one bucket. And I actually want people to start to think about it as, craniocervical instability is kind of a throwaway word, but like atlantoaxial instability is more useful, or looking at where specifically within that system we're seeing the hypergeneration of movement, and what planes it's happening, at what segments it's happening, at what ligamentous structures it's happening, and then using that clinical correlate, I think has a lot of juice. So maybe in the upcoming live, we'll go a little deeper into that and talk about a little bit more specifics on how people can start to think about that and get to a more nuanced outcome. So maybe we'll put that in the next one. John Bond, in one of your past videos, you mentioned GABA/glutamate imbalance as an issue. What causes this now going to be addressed? I don't think that I'm saying that from like a neurotransmitter perspective, because I don't actually think that that's what's happening. Those are just two of the types of neurotransmitters that are being used, the two most prolific ones in the brain. But they're very important because they're what help us be able to maintain a tonic level of inhibition. So in the brain, what's really cool about it is the higher areas of the brain, the outer areas we talked about, I think last week, maybe 2 weeks ago, they kind of inhibit the more internal structures. And we talked about this in terms of the limbic system before. But they inhibit those internal structures as the resting state. So like the resting state of the brain is actually largely inhibitory. It's quieting everything down. And then the way that we can react quickly is just for those areas of the brain to remove the inhibition and then put them back on. So it's like dribbling a basketball in a way. So that's how we create movement. That's how we create thought. That's how we create this electricity that happens through the body. And we can do that in coordinated ways. And the way that we do it, just like the mechanics of it, are largely through GABA pathways that help with the inhibitory barrage. And then underneath that, once that's removed, the glutamic or the glutamate pathways tend to be the more excitatory pathways. And then based on the receptor they're going to, and the combinations of how all these different modalities work in this giant web, that's going to dictate whether or not a neuron fires has an action potential and then propagates the signal on down. And remember, you have gigantic networks of these neurons that are all being activated in different ways. So I actually don't think the neurochemistry imbalance is actually a good way to look at it, because that's the currency that's being used, but it's really being driven by these kind of more electrical impulses that are being generated in these pathways in a coordinated way. I think that's probably a more useful way to think about it. Daniel Zyma. Is there any hope for me as a 23-year-old male with hyperpots? Insane flare-up after meals, blood pressure spikes, PVCs, barely tolerate standing up. His life has been rough. Thank God I work from home. Is there any hope? I would say absolutely. There's hope for sure. But I think hope isn't a strategy also. So let's figure out what hyperpots means for you. Okay. So hyperpots, do we know, like, so for example, the way we measure it is to actually measure the epinephrine outputs, the norepinephrine outputs. And then that's telling us, do we have an open feedback loop that we need to get a better sensor to? Doesn't mean that you're producing too much adrenaline, although maybe we need to check and see if there's a pheochromocytoma to make sure, right? So there are problems you can start to tick off and solve that will lead you down a smaller and smaller and smaller path that'll help you figure out where to go. Okay. But I'm with you. I know this part sucks, and there's other people on here that know this part sucks. But let's find a way to solve the next problem. Okay. So we got to get a little bit more dialed in as to what hyperpots means, and then figuring out what are flare-ups, where are they coming from, what are blood pressure spikes, where are they coming from, how are they related to the PVCs, how does the digestive component matter, whole history, do a full awesome workup wherever you are in the world. I hope there's someone that can start that process for you, and let's get it. But you're 23, you got a lot of life ahead of you, so let's figure it out. Okay. Can candida cause POTS? Oh. Hold on one second. Thanks, Cheryl. Spread it. Thanks for. We got to make the shorts, I think, and then we can spread them. But I appreciate it. So TYYFF. Tiff? What's up? Can candida cause POTS? So to back that out, you can think about like infections writ large, right? So infections in and of themselves will create scenarios that will cause tachycardia, that will cause hyperdynamic blood flow, that'll cause inflammatory responses, candida, specifically if candida is an infection in the gut for sure. So you can think about that writ large. So candida is just one type of fungal infection, but it's telling you that the pH in the gut is not what it should be, and therefore it allows for that fungus to step in and grow. If that's true, then we know that the feedback circles that would keep the pH normal are not working. Therefore, we're not seeing that pH management effectively. And then we get candida on the other side, and we get an infection, and then we may see symptoms from that. So can it cause POTS? For sure. But also, if we have errors in the way that we're controlling that immune or autonomic output, we can create an environment where candida can take over. So it can go both ways. This is the tough part, because when you step into it and you just open the door and you say, what's going on here? And candida looks up at you. We don't know for sure just from that moment if the candida started the fire or if there was an environment there that invited the candida in. So you probably are going to want to look at it from both edges and see how they come back to the middle. So do I need to do things that affect that autonomic output to controlling the integrity of the gut? And then do I also need to just come in and do some things to eradicate that candida so that we can kind of start fresh and build again? But if I eradicate this and hoping to get this, I may not get all the way there. So we want to look at them from both sides. So are there elements of that autonomic output that could be driving the candida response versus the other way around? Or do we just need to get after it and clean up that gut and get the pH back right, and then get the system to run again. But remember, that pH is off in the first place. It means that it wasn't defended. The terrain was poor, the pH was wrong. So that's a pre-existing condition for developing the candida. What is your stance on Pepcid or allergy meds for MCAS? How do you know when to stop? So the allergy meds are going to be there as a way to just stop the end game. This is allopathic medicine writ large, right? So we're going to just suppress the histamine because that's the end order effect of what's going on. It doesn't really tell us how we got there, but it can definitely, for certain people, make those symptoms feel a little bit better. On the other side, though, sometimes it can contribute to other problems as well. So if it's if Pepcid, for example, it may reduce the amount of hydrochloric acid in the system, which may affect your ability to onboard certain nutrients, certain vitamins specifically, and can actually downregulate the amount of hydrochloric acid being produced, which creates new problems with digestion, right? So there's a give and take there. Other allergy meds, if you're thinking more, antihistamine types, can be great, but they can also make people lethargic, drowsy, lightheaded, dizzy, nauseous. So sometimes there's a correlation there where you might make some of the symptoms worse than what you have going on. But for people where they get really bad flares, sometimes those types of medications can be really useful in helping getting through those periods. So you're just kind of giving and taking and figuring out like how to throttle them so that they're the most useful for you. No matter what normal says, MDs are famous for not having a ton of nutritional training. Yep. Is that the same way with chiropractic school and subsequent specializations? I think in some ways, yeah. But that's a good question. And it's maybe not, it's unfair for me to say it that way. I think in anything you kind of get into certain specialties, whether, like a family practice chiropractor may have different expertise than somebody that's interested in neurology like me. The same way a neurologist is going to have just a different level of study and expertise than a general practitioner, right? So it's just people that are kind of focused on a couple different things. For me, I just got super focused in this one thing because that's where patients led me. That was the problem I was asked to solve. So that's what we did. So I would say everybody's a specialist to some degree because it's the thing that lights you up, the problem you're trying to solve, the people you're trying to help. And yeah, chiropractors and MDs we're just kind of taught differently in how to think about those problems, which is wonderful. You want people who think differently. You don't want everybody to think the same, especially if you don't have a thing that is easily solved by the people that think the same. So I think we should celebrate and promote people thinking differently about problems because that's how we all learn. So I learn from people that have thought about problems differently. That's the only reason I'm here, is from learning from other people who figured out how to solve some things and then how to correlate them with other things. So let's celebrate that. Let's look for people that have new ideas. This could be a place where, if you have ideas, we've had that with a couple other people, Dr. Younger. Other people have lots of contributions. The wonderful thing is we don't have to be married to any one thing. Anything that works, we can fold it in. We can bring it to people. We can try to share it. So it's all available. So just being open-minded is probably a great place to start. Another concern families would have would be maybe rather than doing something expensive, just push through it, go for more walks in nature. Is that always the help? No. Background information: if I have suspected obstruction to blood flow in my neck and poor recovery time from short walks, short walking's not going to fix it. You got to fix the problem you have. Nature's wonderful. I love it. I like to go for walks. I would love to see everybody do it. That's a great goal. But if you have a broken ankle, going for a run isn't going to solve your broken ankle. You got to heal the thing that's wrong. And whatever that means for you is trying to attack it and go right for that thing. Working toward the specific solution is probably more useful than applying just general health policies. Although we support and love all general health policies, But then there are times when we actually need specific things as well. So there you go. Piggyback on John Bond's question, how do amino acids play a part in autonomic function dysfunction? Could an imbalance make it worse? So amino acids are what we make proteins out of. It's like what our whole structure, our whole body is made from. So if you're in a severely nutrient compromised scenario where your diet reflects the fact that your amino acid profiles, your branched chain amino acids, your essential amino acids aren't sufficient, you got to address that. And this comes with just like eating a solid diet, not a standard American diet, but eat a solid diet. It's branched chain amino acids, essential amino acid supplements are wildly cheap. So you can do those things, but solve, that general diet portion, like get that tight, like work at it, eat good food. Don't eat candy all the time. Try to eat things that are organic, things that don't have a bunch of chemicals in them, things that spoil easily. Try to eat that stuff and eat it before it spoils, and try to eat, if we're worried about amino acids, you're going to probably want to eat some meat. You're going to probably want to eat variety of it, different types of animals, but also different cuts, different, using organ meat, using the liver. All those things are really helpful. Now, will that fix it? I don't know, but it's not going to break you. It's certainly not going to make it worse. And having a full complement of appropriate amino acids, vitamins, nutrients, minerals, you're only going to do yourself a favor to do that well. And it'll definitely help. It may not fix it all, but it's definitely a push in the right direction. I would advise, well, I'm not giving advice, but like anybody, starting there is a good thing. And it's a thing, like when you're feeling out of control, a lot of people turn to diet, medication, supplements because it's a thing that you can control. You're putting it in your body. It's something that you're doing to try to solve it. And it's a way that you can kind of take command of what's going on. So it's a good question. Okay. What do we got here? All right. I'm going to do a couple more. Andrea, I have a positive TIL test, but no POTS regimen helps my symptoms at all caps. Dizziness and panic are the two. Tried it all. Only thing that helps is small doses of Klonopin. Does that mean anxiety is causing it? I don't know for sure. But if Klonopin helps with the dizziness and panic, then there's a probability that that's coming from in the old brain there. I don't know what dizziness looks like for you, but it's definitely worth talking about. It may be worth doing something like a biofeedback or a neurofeedback type of program that helps you to be able to work through that. I have to know a ton more about the case, but it certainly would be something to explore if that's what you're noticing. Aaron, what could it mean if one pupil is smaller than the other? Well, good question. So if you go through kind of the diagnostic process of that, if one pupil is bigger than the other, what you're trying to determine first is which one's the right size one and which one's the wrong size one. So if we're finding that one pupil is way big, it's too big. If a pupil's too big, then it means that you're getting a lack of parasympathetic control of that pupil, and it's causing a full dilation of that. So there's nothing opposing. You got two different types of muscles. You got muscles that squeeze like this on the inside, and then you got muscles that are like spokes that pull like this on the outside. So if the ones that are pulling like spokes are kind of pulling against the ones that are circular like this as well. But if these are relaxed, it lets those spoke ones pull really easily. And so if these are not getting a signal, whether it's from a nerve injury or a ganglion injury, then that pupil can get really big, right? Okay. And then you want to see if it's reactive. So if you shine a light in it and it still gets small, then it means it's capable of doing that. It just isn't doing it when you want it to. So it's a coordination thing. And then you check that eye to eye, right? Now, in the instance that the pupil is too small, we think about it the other way. That muscle is like stuck rigid, or it means the spoke ones on the outside are not giving any tension. So these ones are unopposed, and they're pulling too tight, right? And that can happen if we've got an injury in the sympathetic chain coming up the old neck here and then to the back of the eye. If that gets damaged, then we'll see we'll see that pupil gets really small. This is meiosis. Horner syndrome is kind of the classic one for that, where the pupil gets real small on that side, and then your face gets dry and like it doesn't get oily, it's not sweating, and then you'll see where the lid, your pupil or your upper lid starts to droop a little bit, and we call that ptosis. So those are the three things that tend to go with if we've got an injury in that nerve that comes up and goes to the back of the eye there. So it can kind of work both ways, but those are the basics of it. But we can also have, if we get injured in the frontal lobe or its projections into the locus coeruleus or the midbrain, then it may affect them asymmetrically. If my brain is injured in an asymmetric way, then we might see that, if I have an injury over here, I might see that pupil is a little bit bigger. When I shine a light in it, it might not constrict as hard, or it might blow out faster again. So actually looking at the pupils is an amazing way it is an amazing tool for understanding brain injury, peripheral nerve injuries, what's going on in that noggin. So it's called an anisocoria. That's a fancy word for it. That just means they're not the same. The bigger eye we call a corictasia. So if you want to look those things up, that might be helpful. Okay. Can a concussion trigger venous sinus stenosis to be symptomatic or worsened? Typically, unless we're moving some tissue around in there and causing like some swelling or some compression, those are going to be the things that are most likely. Otherwise, these can be just like variants of how people are born as well. Let me see. So specific to the venous sinus, you're really looking at things that would potentially cause some sort of structural change in the brain that would then cause a backup into that sinus. Obviously, if it's stenosis, and that's not going to be something that's further down the chain. That's going to be specific in the back of the head there. Okay. Can regular POTS turn into hyperPOTS? That's not the best way to think about it. So regular POTS is just, there's not a regular POTS. There's just different forms of how you get tachycardia. So it's a good question. I don't mean to make it sound bad, but hyperadrenergic POTS means that we've got an increased output of sympathetic nerve fiber activity that's unmitigated. So it's like you ordered a package from Amazon, but the driver never says that you got it. So they just keep sending it over and over and over again. And next thing you know, you've got 50 boxes of, microphone stands, and you're like, I don't need all these. So that's kind of what you're measuring when that norepinephrine rate goes up, and it spills over, and it causes you to have responses in other systems as well. And that's why you kind of has that sensation with it. So you said you're sick 2 years ago with COVID, dealing with the bad breakup, distress and illness caused me to develop classic POTS. After a month, it changed to hyperPOTS. I think that might be the misnomer, is POTS would be more of an umbrella, and then you might divide that into different types. It doesn't mean that it is its own type and then these are their own types. POTS it just means that when I stand up, my heart rate goes high, but my blood pressure doesn't change. That's all it means. And then the question is from there is like, what's causing it? So in hyperPOTS, lots of things might be causing it. You're just cranking out heart rate to deal with it. And as a consequence, the other things that go with having that high heart rate also start to become symptomatic. I feel a little anxious. I'm getting palpitations. I'm getting sweaty because that system's driving so hard, right? Whereas if I've got what's classically called hypovolemic POTS, we don't have a way to actually measure that's true, but that may be more related to the fact that we're not able to get sufficient preload back to the heart. We have to solve that problem maybe a little bit differently, maybe not. It might just be the way it's presenting. And then you think about neuropathic POTS, where the nerves themselves have damage and they're not able to create the constriction. But all of these are really the same problem, just expressing itself in different ways. So a more useful way is to look at the mechanics of what is failing. It's like people were talking about, am I compressing something in my neck? So as hard as my heart wants to pump, I'm not getting blood flow to my head. You got to solve that problem differently than if there's a problem with the baroreceptors and they're not sensing the pressure changes. Different type of problem, right? If I've got an autoregulatory problem where the blood vessels in my head are not responding to changes in pressure and it allows that pressure to drop out of my head, got to solve that differently. If I'm having problems with the innervation to the vasculature of my gut and we're seeing that there's too much venous stasis when I move, when it should be more responsive, solve that one differently. If I've got peripheral neuropathy, solve that one differently. So, I've got a cortical problem in my brain and I don't recognize a portion of my body, or my visual system doesn't tell me where my head. So like there's all these different mechanisms that can go on that are probably more useful to try to understand, especially knowing that you got sick and dealing with a breakup. I'm sorry to hear that. So that's probably the way I would start to look at it, and that might be more useful for you. So good luck. Kim says, I don't have papilledema. I have retinal nerve fiber layer rim thickness. I bend down, I lose vision mostly in my right eye. If I don't have PAPs, how could this still happen? I also have venous stenosis. My lumbar, I think my opening pressure, maybe that you might say, lumbar puncture, was 28. Well, that's very interesting. So it can still happen if people are losing vision. Well, number one, if you don't have papilledema, but you're having some retinal thickening, it may be transient too, so where it's coming and going. May also be, you want to look at the vasculature in the eye and see if you're getting stenosis in the vasculature coming through the ophthalmic artery or through carotid stenosis. Because if we're having carotid stenosis or compression or ophthalmic compression, then it may be that we're choking it off even further up the stream. Might be one thing to look at. So you could look at doing tests like we do. You could look at doing something like a CT angiography or MR angiography and seeing if that looks to be the case, or using dynamic ultrasound testing might be helpful next step too. Aaron's music says, what studies and data constitute the levels of cerebral blood flow the clinic looks for? That's a good question. We use the data that mostly comes out of the autonomic testing book from Peter Novak, and then there was some other work. Actually, one of my favorite ways to decide to think about it, they ran these studies. It's been a few years now, where they were rotor-rooting people's carotid arteries, doing carotid endarterectomies. Basically, they get too gummed up in the artery and they try to clean it out. They were finding certain people were having strokes on the table, which is not great. And so what they started to do is run these Doppler studies where they would look at, because when they do the test, they got to crank your head over so they can access the carotid, right? So your head's turned. So they started looking at that and saying, like, man, it turns out the people that have more than a 20% change, and they're laying down, but a more than a 20% change, they were more likely to have a stroke. So that was kind of their cutoff for, like, if somebody turns their head and it drops that carotid flow that much, then we don't want to put them in that position because it's going to have a high potential for a stroke. So that's the data we use when we look at head turns seated in people that are active. So what that means is we use it like a very conservative measure to be able to look at the change. So basically, it's the people that are most likely to stroke during that movement. We want to say, like, we want to be at least as good as those people when we turn our head. And then a lot of the data that we use comes from what was published through Peter Novak's group, and then based on like our clinical correlates to that data set. So that's where we get it from. So that's I think that was established in like 2016. Yeah, it's worth reading. They wrote some great papers about that too. If you're a super nerd like me. Can we have one Thursday dedicated to EMFs? Maybe so. We're all going to be wearing tinfoil though if that happens. So be careful what you wish for. Where are we here? Okay. Okay, I'm going to do a couple more. Anson says, I have all these issues categorically and horrible perfusion, neuropathy, no sweating. Wondering why Klonopin is the only thing that modestly helps and allows some sweating and such. Because you're changing the central outputs is the short answer to that. So we're just creating less of a barrage into that, into the thalamus, into the filtering system. So it just cools it down. Good to look at. Christina says, do you see any correlation between POTS and coronary microvascular dysfunction? So the microvasculature is going to be the vasculature that is going to actually supply the blood flow to the muscle of the heart. And so if we're constricting those vessels, kind of we think about that the same way we would if we're constricting them to the brain, the heart's not going to be as efficient. But it may or may not correlate to how the circulation is doing. So when we look at the intrinsic capacity of the heart, we want to look at that microvasculature and see if it's affecting either the preload, the ejection fraction, the cardiac output, to understand if we're losing efficiency within the cardiac tissue itself, or if that's a function of the neurological control of the vasculature. Cool. Mary, do you do the tilt table test with the cranial Doppler together? Yeah, that's yep. If so, how do I get a doctor to do that? I don't know. We got to train them. We got to get them excited about it. We got to get them excited about it. That's why we share cases and why we talk about stuff. We got to show them how to do it. There are plenty of resources for that, and then get it so that eventually it becomes like the normal thing that everybody gets. That would be the ultimate goal. Does cerebral hypoperfusion heighten the risk of stroke? It seems to. We don't have that specific study, but it seems to be that you're more likely to have a transient ischemic attack or an ischemic stroke, unfortunately, and then makes you a little bit more vulnerable to vascular dementias. Some of the neurodegenerative components that come with not feeding the brain super well. Again, that's why we're here. That's why I fired up talking about it on Thursday night, trying to help people out with this. Okay, so last one. Cheryl said, oops, was I supposed to be wearing my foil hat this whole time? Why do you think I'm in this black room? Just trying to hide from all of it. Can you discuss kidney pain and POTS? Many thanks. Okay, interesting. We don't hear that one a lot. And it's hard to know how they're related. If the kidney pain is referral, like from the kidneys themselves, or if it's interneuronal, or it's a referral from a more central area. That's a good question. I don't know the origin for sure of what the kidney pain would be in every individual. Not to say that for sure you can have it, but I don't know precisely why that would be in any one case. We'd have to just go through all the testing, looking at kidney function, inflammation, looking at the nerves that are going in and out of that, look at the kind of the flow rates and figure out if there's something wrong with the kidneys themselves, if we're seeing pooling in the system, kind of working through all that. But it's a good question, but it's a little general for where we're at right now. Maybe we'll do a longer form where we can discuss that more. Megafixel says, oh, that's a kind one. I'm going to put this up just to pump my tires a little bit here, and then we'll say goodnight. Your knowledge and expertise has been incredibly helpful over here in South Africa. I appreciate that. I initially presented exactly 4 years ago with first onset seizure, ongoing periods of amnesia, cognitive impairment. I appreciate you saying that. Hope that's going to turn into a great story at the end. So dysautonomia and POTS so followed, and eventually 4 years later, SLE was confirmed on SPECT. There we go. Nice find, actually. That's really good. What is the mortality rate with autonomic dysfunction? I don't know the answer to that. I think we're more in the morbidity than mortality. So like the quality of life really is the main driver for a lot of people. Some people have POTS from renal vein compression. Some do, but not a lot. not to cause fear, but you can have compression of any vein and artery in the whole system of the body. That's the thing to remember. Okay, I think we did it, team. Bill Thompson says thank you. Thiessen, nice catch. Sasha, great teammate here. Great questions out of everybody. Nice work. Really useful stuff. Hope it was useful to you. I'm a little bit tired, I gotta say. That felt like I was doing a lot of talking. So appreciate all the questions. I'm gonna go have a drink of water and go to bed. We got a big day tomorrow. We got clinic day, and then we also have first day of the Holland hockey tournament, and we have the in-house gymnastics meet. So it's gonna be a big day tomorrow. So I gotta be in full dad mode and clinic mode. So I'm gonna try to get some sleep. Thanks for being here. We'll be back next Thursday. Different location though. Probably won't be in the black room, but you'll have to see. Thanks for being here. Love you guys. We'll see you next week. Take care.